Again, my name is Anja Wilkinson. I've been in the 340B space for about 9 years now. Started back in 2012, had absolutely no idea what 340B was. And, what a roller coaster of a ride. So here's just a little bit about the agenda. I'm going to look at the compliance overview, specifically touch base on HRSA's audits. Who are they targeting? What are they, seeking or looking for? And then also how to incorporate compliance into your program. Everything that I do show is something that I've developed along the way. And I have been through a HRSA audit. And so I really took that report and really honed in on how can I incorporate this into the CE's actual audit process. So just an overview of compliance. And again, these are things that I have put into place. And so please keep that in mind that these are definitely something that came from a HRSA audit, talking to other covered entities, looking at, of course, APEXIS and what they're recommending. So within the covered entities that I have been involved in, we had daily tasks. We had monthly, quarterly, and yearly tasks that the audit team would look at. The analysts, into the software. What are we looking for? How do we determine ahead of time maybe something that the EMR is not producing correctly? Look at our reporting. And so, one thing I can stress is there are some CEs that are smaller and they only look at quarterly audits. And just to kind of give you my idea that if something is going awry, so to speak, in the middle of January and quarterly audits are not done until April, you have 8, 10, 12 weeks of having to undo something. And if you're looking at them more on a monthly basis, then you're able to hone in on that maybe compliance issue and be able to walk through your program and develop a plan to correct that issue. I also think that there needs to be some internal discussion and a process in case a compliance issue is discovered. Doing that on the forefront instead of, or being proactive instead of reactive can definitely lower the stress level. I identify the weaknesses as well as the strengths within our programs that I've been involved in. We tend to almost always look at the weaknesses, but you need to also give praise to your strengths. Use your resources within the 340B space. Open up all lines of communications, whether it be internally or with another CE, association meetings, breakout sessions like this that specifically target 340B and some of the input from people that have actually been within a covered entity. Look at APEXIS. 340B Health, they're both, obviously APEXIS is the prime vendor for HRSA. 340B Health also is an advocate in Washington, D.C. that provides a lot of webinars and different things like that for covered entities to learn from. One thing I can only say over and over is, plan. Conduct your external audits, have an agency or a specific audit organization come in and look at your 340B program. Allow them the time to go through your policies and procedures. Look at your audit templates. What are you auditing? How does that make sense? Does it make sense? Where are some of your weaknesses? In my opinion, obviously, you would want this to happen because you're bringing someone in to assess your program instead of possibly having a finding later in a true HRSA audit. And then an internal roadmap, and I call this the who, what, when, where, and how. There's so many different departments depending on how large or small the CE is. And to me, you can't have enough input from different departments. So obviously, OPACE registrations, right now we're in the middle of recertification. So I will just say, please don't forget to recertify your covered entity. If you do not recertify, then you can be dropped from the program. Look at Medicaid. State specific, are you a carve in, carve out? What does that look like from a mixed use or a contract pharmacy perspective? Also look at the location of where your organization is at. Do you have a lot of out-of-state Medicaid? Always think about the out-of-state and how are those bills being dropped? Are you going to include it? Does that state allow that to be carved in? Also, carve out from a contract pharmacy. I'm from Oklahoma, and we are carve out completely for contract pharmacy. If you have managed Medicaid within your state, that could be different. So definitely opening those lines of communication with your state Medicaid office. Also look to Apexis. They do have a specific link to contacts within each state. Billing modifiers, if they're able to find that information. I know that database is not necessarily updated on a regular basis, but at least it gives you something to go to and reach out to your state Medicaid office. Your Medicare cost report, you need to ask for that report yearly. As soon as whatever department puts that or generates that report, you need to look at that. You need to look at your trial balance. You need to look at all of the items that are on the reimbursable lines of the cost report. Did a location move? Did they add one? Sometimes that's not communicated across a health system, and you would be surprised how many times that maybe a department moved outside the four walls and no one told 340B. And so then, you're having to decide, okay, where are they at? I need to register. What does that look like? And then you come to your 340B software. What services do they offer? Do they have any type of internal audit reports? Do they actually have an internal audit team that actually reviews your OPACE registration, looks at your addresses? Are they able to put a report together for you? And then also, I think what is very, very important is, are they available to support the CE during a HRSA audit? It is not their responsibility for the CE to pass that audit. We all know that the responsibility lies at the CE, but there has to be a collaboration to know that we're all in this together, and to have them on site during a HRSA audit. Although I know right now they're virtual, it's still an added, service for that 340B software. And then, work with your internal audit department if you have one. Look at a risk assessment. What is a low, medium, and high risk? And define by audit findings. Is diversion, we all know, is a high risk. Where do you fall on that pendulum, so to speak? What processes or tasks do you have within your own program to overcome if you do have a shortcoming? And then again, manufacturer inquiry. And we all have some as Melissa said earlier, 340B's changing manufacturers, what are they up to? And I'll kind of recap that just in a little bit, but communication is key. If a manufacturer reaches out to you directly for some type of information, do not ignore it. Definitely hold that key of communication with them. Obviously, within how your legal department feels that communication can be and what information they're comfortable with providing. But HRSA does say that, those types of communications need to be between the manufacturer and the CE. So just some kind of recaps of audits that HRSA is doing. They're approximately 200 per year. 78% of those are on hospitals. Obviously, they're one of the largest groups, and so they're going to be more focused. Diversion. So it's interesting, when HRSA started audits, the CE knew what diversion meant, knew what duplicate discount meant, but we didn't have any true guidelines as to how to incorporate that within our 340B program. And so when the hospitals and other covered entities were being audited, that's what they were focused on, is diversion. And then they were focused also on duplicate discounts. There have been decreases in both of those, which tells me that CEs are listening and they're understanding, and they're trying to change their program to make sure that those two key audit findings are addressed within their program. And then, audit, we sometimes not think about the OPACE database. And this is so key, registering all your child sites. Like I said earlier, with the crosswalks, with the Medicare cost report each year, again, did they move a location that was in the four walls to outside the four walls? Does that need to be registered? So always verify that. Look at your addresses. It's one of those, in my opinion, if street is spelled out, then you need to spell it out in the OPACE database. That address needs to be exactly how that particular location's license is written in. What is it, street, STRET, or is it ST period? So always look at those things. Your Medicare exclusion or Medicaid, exclusion file. Make sure that if you are billing out-of-state Medicaid, are those included within this file on the OPACE database? Review that with your billing department, patient accounting, revenue integrity, whatever that department is called. There have been some areas for improvements. Delete any duplicate registrations. And I know that sounds, almost strange in a way, but there have been issues or circumstances that the same location was registered. So make sure you're looking at that. Also, do not forget about your AO and your PC. If one of them leaves the organization, make sure that you update that on the OPACE database. And then audit findings. A CE can dispute a finding. HRSA will review the documentation. There's communication back and forth with the CE and HRSA. Remember that you can upload that information and you can dispute it. And if you feel that you can tell what I call that story of that 340B patient, then make sure that you respond in the time allotted and make sure that you're providing all the documentation that you can to justify your case. And then, of course, within the audit report, you could possibly have an AFI or an area for improvement. So although this is not a finding, your auditor's saying, you need to look at this, define this a little bit more. Hey, you need to change your PSA to say this, something that is just basically even more compliant. And those need to be addressed as soon as possible also. So we do have some updates for FY21. We all know that last summer, HRSA came out with a clarification that said, the 340B world thought that a child site or a provider-based clinic had to wait until the most recently filed cost report, which is in November. We couldn't register it to January, and then it go live in April. So HRSA came out with a clarification last year that said those sites are eligible immediately, but you need to make sure that within your 340B policies and procedures, you address this and what process are you taking from a covered entity perspective to make sure that you're compliant and that you will need to register that child site as soon as that Medicare cost report is filed. They're also looking for purchases for each account. Years ago, they were only looking at 340B purchases, and now they're actually looking at that across all accounts, whether it be just 340B GPO or if it's 340B GPO and WAC. And then also they're requiring more medical or Medicaid billing documentation and information. I can say that in my experience, I had an open communication with patient accounting, thought we had all of the Medicaid numbers, MPIs on the OPACE website. However, during an external, I call them an external assessment, a company came in and said, you're not as, you're missing one. And so again, open that line of communication across all of your departments within your health system, just so you know when changes are being made. So HRSA will send out an email. It will go to the AO and PC that are registered on their website. So again, just make sure that information is up to date. You'll have a kickoff call with the auditor, introduction of the parties. You're able to ask specific questions. I know one question that I asked, because they're wanting a lot of data to be uploaded into this secured portal. What type? Is Excel okay? Do you want it in a different format? How do you want it loaded? Can we load it, in bits and pieces, or do you want it all loaded at the same time? I will say how I looked at this is I uploaded the documentation specifically based on the data request. So if they're wanting the policies and procedures first, then that was the first thing that I uploaded. So I tried to make it in the order that is on the data request from HRSA. The CE submits all the requested data through the secured portal. Then they're either on site or virtual. I will say the audit that I was involved in was actually on site, and we didn't know the sample until she was actually on site and we were going through our EMR with her. The virtual is a little bit different. They are able to provide that data sample to the CE prior to the audit. So you're able to go through it and provide it, download any documentation, ready to have it available. So that's a little bit different with the virtual. The report will come out, and sometimes they take 3 months, sometimes they take 6 months, some are a little bit longer. But once that report comes out, if you do have a finding, address it immediately. Internally, what does that look like? Put a CAP together, you respond to it. If it's something that, let's say it's diversion, they actually had, the CE had that particular audit finding. What are you doing internally to make sure that this doesn't happen again? That's very, very important to HRSA to accept that CAP from the CE. So mixed use, look at your 340B software. What services do they provide? How do the reports look? How is the information uploaded? Work with them. They're, again, like I said earlier, they're not responsible for your compliance as a CE, but they are a tool within the 340B arena to make sure that you do stay compliant. Look at your patient type / status. Depending on your EMR, I'm very, very familiar with Epic. So, I always look at the patient type or the patient or the patient class tells me what type of services they were having. So always know how your EMR looks and where do you go to find that information. And then, of course, we all know the department / location of the drug. Where is it being administered? I've had a lot of questions when it regards the ER. When you hear the ER, you automatically think that it's an outpatient. But we need to remember, especially as we talked earlier about COVID and how things are ramping back up, unfortunately. And sometimes we have a patient that's actually in the ER, but they're an inpatient. And that's because we don't have a bed yet. And so make sure when you're looking through your data, look at that. So just because it's an ER location of when the drug is administered, check to see what your actual patient class or type is, because that's going to play a part in this. And then from a contract pharmacy perspective, discharge script, what location was the script written? What's the NPI list? What's the relationship to the CE? Is there some type of contractual arrangement with the CE? And then there's a lot of talk still about referral documentation. What does that look like for your covered entity? Are you documenting, or is case management documenting any type of notes back from the referral that went from your CE? Make sure that that's within your EMR, that you're showing that you're keeping that open lines of communication. And then who holds the responsibility of care for that patient? If your CE is referring someone out and the referring physician is not seeing that patient anymore, it's all back over to the referral. That's where you draw, some red flags, because the responsibility of care is not coming back to the referring physician. So just kind of walk through that. The way I explain it is tell that story. Can you tell a story for that patient? Do you hold the responsibility of care? They were referred out, they come back to possibly a clinic. And so then the clinic physician takes back over the care. So just, walk through that and make sure that you can follow that patient, and that during an audit, you're able to show the referral, the documentation, and that you held the responsibility of care for that patient. So here is just part of a HRSA data request. And this is what I was referring to as I loaded the documentation specifically through in the same order that the data request required. Description of the CE registration, recertification, who does it, how is it done, process for ensuring that the 340B OPACE record is up to date. And they're looking for some of this information in your policies and procedures. And I can say they review their policies, the policies and procedures in detail. And you will have questions asked specifically to that policy and procedure. So if it's in that document, make sure that you can address it and explain it, and that it's actually happening the exact way that it says in that document within the CE. What are you looking at for your procurement? Contract pharmacy, if it's applicable, how are you making sure that things are flowing correctly from the mixed use perspective? Who's placing the orders? Define your 340B software and how that works to ensure that everything is being purchased based on your accumulations. If you have the type of dish, pediatric, cancer, how are you trying to prevent GPO violations? What steps are you taking internally to address that? Now, that obviously GPO violations prohibition only affects certain CEs. And then there's been a lot of talk through the years with exclusions to the definition of covered outpatient drugs. I can speak from experience. We exclude basic IV fluids. And so it's defined in our policies and procedures. And then it's also defined in how do we make sure that our buyers are not purchasing basic IV fluids on a 340B account. What does that look like within your software? You need to be able to exclude those NDCs, that drug class within your software to ensure that you aren't in violation of what you or the CE has defined it as a covered outpatient drug. I've worked for an organization that actually excluded all contrast. And again, just define it and make sure that within your software that it's set up to exclude those drugs. What are you doing for contract pharmacy? We know that HRSA's recommendation, strong recommendation, is that your contract pharmacies are audited by an external firm on a yearly basis. That's just to bring someone in and actually look and define to make sure that you're compliant. Again, I have an organization come in yearly. I would rather them find a possible compliance issue, address it internally, than come to the realization during a HRSA audit. How are you looking at the accounts, 340B inventory, replenishment? How does the accumulation look? Are you an NDC to NDC crosswalk? Are you physical inventory versus virtual? I've worked both with the CDM NDC crosswalk and an NDC to NDC. I can say, in my opinion, that the NDC to NDC crosswalk is much more easier, I guess, to remain compliant, in my opinion, because whatever NDC is passing from your EMR is what was scanned upon administration. Where you can have some issues with that is if they didn't scan. Within Epic, like I said, I have experience with Epic, and if the default's not set appropriately, then you possibly could be passing an NDC that the organization doesn't even purchase, and you're not able to accumulate until internally that's corrected within the EMR. Again, prevention of diversion. What does that look like? What are you doing? Who's responsible for it? Have that within your policies and procedures. Mechanism to prevent duplicate discount. Again, offsite outpatient facilities, contract pharmacies, carve in, carve out. There's a lot of talk of duplicate discounts over the years, and the manufacturer are providing the drug at a 340B discount, and then Medicaid's coming in and asking for a rebate. So definitely have those conversations internally on what that looks like and how it needs to be registered and how you're going to address it, and have that in your policies and procedures. And then also, define or determine how you're going to disclose. If you find a compliance breach internally, what does that look like? Make sure that you have some type of policy that says, if we have a material breach and it will not correct it, and this is just an example, if it will not correct itself within 6 months, then that's a breach and we need to report. Some covered entities has said, well, if it's 3% of our total 340B purchases, then if it's over that 3%, we will self-report. So just make sure that you define that. So that's involving legal. What does that look like? How are you going to actually disclose? I've had to do this before. And I provided the manufacturer with all of the documentation that said we did have a material breach. Here's what's happened. Here's our cap on how we corrected this to ensure that this does not happen again. They were open that line of communication. They responded. I had a certain dollar amount. They did their checks on their side and came back and said, we've determined that you only owe us X dollar. So again, they're not necessarily quote unquote the bad person. They will work with covered entities. I can just say that within that self-disclosure, make sure that you put in the steps that you're taking internally to make sure that this doesn't happen again. And then pre-plan for an audit. Some organizations don't look at this until they get that HRSA notification. Hey, you're going to be audited. I will recommend that you do this yearly. Look at who's responsible for each task. Again, is it legal? Is it your 340B manager? Bring in your systems manager, obviously director of pharmacy, bring in finance and patient accounting. Those all need to be part of your internal audit plan. And the more they're involved, almost conduct a mock audit, if you will. That way they know some of the questions, they know how the process is going to work, and you're not scrambling once that notification comes to you or your AOPC. So you know ahead of time, hey, we have this already defined. Here's what we need to do. Maybe it's your system manager that is responsible for pulling all of your 340B dispensations from the software, or just define that ahead of time so you at least have some type of roadmap when you do receive that notification. And so earlier I had said, I've developed the compliance aspect, daily, weekly, monthly, quarterly, and annually. Daily are your drug utilization files going over. Is your patient encounter information from a contract pharmacy perspective? Those are daily files that have to go over to your software to make sure, one, that you're accumulating correctly, or that prescriptions are qualifying at the contract pharmacy. So those are daily files that need to be verified. Yes, it went into the software. And so look at those. And then on a weekly basis, review your audit drug data. Make sure, select a couple of them, look at them, walk through Epic. It doesn't have to be a 3 or 4 hour look each week, but just spot check them just to make sure. Look at your drug purchases. We at the organization that I am at, we look at WAC purchases every day. We're a dish hospital. We have WAC, so we're looking at that every day. It helps with what I call negative WAC spend, because we do know that Apexis contracts are loaded on the WAC account. So it may be a sub WAC price, and that is the best price. But again, we look at that every day to make sure that we're accumulating appropriately, that it's truly going to WAC because it's the first purchase or it's the best price. Also, don't forget about manual purchases, especially now with some shortages. We're having to go direct with some of the manufacturers outside our wholesaler. Well, if that EDI feed is not set up with your 340B software, then those purchases are not hitting your accumulators. And so make sure that you're looking at that every day, every week, whatever that looks like. Have that open line of communication with your buyers to make sure that they're notifying you or providing you with an invoice to make sure that your accumulations are accurate. And then you can also look at your non-captured claims or non-qualified claims within contract pharmacy? Is it possible, do you need to update a written location? Do you need to update an MPI file? Is your patient encounter file not pulling that data in? I know that some softwares, their patient encounter file, that data does not go over to the software until a final bill has dropped. So has the final bill not dropped? And that's why it's not qualifying yet. And then always review your accumulations. Look at your negative accumulations. I always say those negative accumulations, that's an immediate red flag. So always look at those. Determine if there's something internally that needs to change. Is something not linked appropriately within your software? But it's highly important to look at those accumulations. And then, of course, monthly, look at your self-audit, both with the CP and the mixed use. Look at your software. What type of audit function do they provide? Can you do it in their portal? Walk through the process. What are they looking at? Are they looking at the location? Are they looking at the insurance? Are they looking at the MPI? Make sure that you look at all of that. And don't forget to update your MPI and addresses. Remember that providers move away from the CE, come to the CE. I know that in July, when there's a shift in the residents, that's always a huge manual process to update those MPIs and addresses in the software, but it needs to be done. Have communication with your physician credentialing office. See if they'll copy you on an email or send you an update every month if they have a board meeting to approve specific providers. Make sure that you're getting that information and you're updating your software. BUP reviews, billing units per package. Make sure that they are set appropriately within your software. I've worked with, like I said, Epic, so we have an implied quantity, which we pull into our daily drug utilization file. Some covered entities use billing units, and that's perfectly fine. The one thing I will say with billing units is to make sure that someone is verifying on a monthly or quarterly basis that if there are any changes to those HCPCS codes or how they're being billed to Medicare, that you're also updating your billing units or package size within your software. Also, look at your OPACE database. Look at that, download it, go through it on a quarterly basis. Review your Medicaid exclusion file. Also, one thing that I have found to be very beneficial is to verify that that quarterly contract load has happened between the wholesaler and the 340B software. We all know 340B pricing is updated quarterly, so we need to make sure that your software is at least looking at that pricing on a quarterly basis. And then annually, like I talked about earlier, your Medicare cost reports updates, go through that with whomever's putting that report together, whether it be reimbursement, patient accounting, reimbursement, integrity, but walk through that and ask questions. I am asked quite frequently, well, how does that calculation to the dish percentage work? And if anyone's actually looked at that calculation, there's so many pieces to that. And so I definitely say, that's not my area of expertise. That is pulling in a lot of different data. And that's where that Medicare cost report comes into play. Recertification, like I said earlier, we're actually within a recertification period now. I will say definitely, my recommendation would be to get that completed as soon as possible. I actually went online yesterday to try to do that yesterday evening, and the system was down for me. So, don't wait till the last minute. Go ahead and do it. If you have multiple covered entities, do one at a time, walk through it. Make sure that if you are the PC, that you reach out to your AO. So the PC can do all of the research. However, the AO has to attest to that. Make sure you look at your governmental, if it pertains to your covered entity type, look at your governmental official that's registered. Make sure that there's still that point of contact. If not, who is that next point? Who do you need to update that to? Look at your policy and procedure. Is there something? My recommendation is to review the full policy and procedure yearly, just like with any other SOP or process within a hospital setting. Look at those and see if they need to be updated. Has someone left the organization? So you may need to redefine the roles within your policies and procedures. So definitely look at that. My recommendation too is to look at the 340B steering committee, ask for their recommendation, bring it to them and say, XYZ, this is a recommendation, or this is due to new HRSA findings. So look at those. And then of course your external audit, you can bring in, I call it an audit. I like the word assessment. Audit sometimes tends to have a negative connotation, and it's an assessment. You're bringing someone in to look at your program and to find weaknesses so that you can better the compliance side within the 340B. Here's just an example of some audits. I will admit I'm a Excel person, so I like to download everything into Excel, set up VLOOKUPs, how can we automate it as much as possible? Looking from a mixed use. Obviously, is the CE a patient of, or is the patient actually at the CE? Can you define that patient relationship? What's the patient class? Verify the med and the EMR. So I'm pulling this information from a 340B software, and then I'm going to the EMR and I'm verifying, yes, that was dispensed to that patient. We verify the quantity, the NDC. We look at the billing units per package. We make sure that calculation between what was administered and what the billing units are, that we're verifying that, yes, the accumulation within the 340B accumulator is correct. If it's a vial of 100 milligrams, we dispensed 85, we should see 0.85 within the accumulator for the administration, knowing that there's a waste charge also. And then the insurance. Again, pulling this information from their 340B software, then validating that within your EMR. And so those are just some of the things that we look at from a mixed use perspective. And then a contract pharmacy, a little bit different, but conceptually the same. Look at your high dollar, high volume. It has been said that HRSA does target audit as well as random, and your target audit will be your high dollar drugs, possibly your Altaplace, things like that. So definitely focus on high dollar, high volume. Look at the location on the prescription file from the EMR. Does that actually match a registered location in the OPACE database? Then look at where the patient was. Where did they discharge from? Again, address on the script. Does it match the OPACE? Look at your MPI. Is that particular person out of your EMR truly on the provider list within the organization? I will say that once a year when we do this, we do request the contracts or whatever type of document that our credentialing office has, just like within a mock audit. They're going to ask for that in a true HRSA audit. And so I'll send them an email that says, I need, provider 1, 2, 3, 4. I need to see what type of contract we have. Can you provide that to me? You will possibly have some more questions. Why do you need it? What are you doing? And just explain to them that, within the 340B or process, you have to determine and verify that MPI does have some type of contractual arrangement with the CE. And then what is the MPI in the EMR? So you have, again, your data from your 340B software. Is that the same information that you're finding in the EMR? It's just a double check to make sure that those files that are coming from your EMR are correct, are accurate. That's very, very important. Was the drug on the script actually what was dispensed? I know that sounds strange. You would think that, oh, that never happens, but we all know when a prescription goes over to a pharmacy, and let's say it's for 20 milligrams or something, and the pharmacy only has 10 milligrams, or whatever that looks like. just have that open line of communication with your contract pharmacy. It's a little bit difficult with possibly like a Walgreens and a CVS, but you do have some type of an account manager that you can reach out to. And then again, I'm very, very familiar with Epic. And so we look at the AVS, which is your after visit summary. Is that drug specified in that after visit summary? Is it on there? I think that's important because it proves, or it shows that story, and that yes, that the patient was given this AVS, and it specifically says pick up X drug at certain place. Also verify your EMR, the insurance. So we do have, again, we're from Oklahoma. We carve out all of the contract pharmacy scripts. There are times that a patient goes to the pharmacy and let's say it may be cheaper for them to process as a cash payment instead of filling it on their Medicaid. And so we always verify the insurance and the EMR also. We look at the date the patient was discharged. Does the patient date, does the date written equal the discharge date? I will say there will be instances that this does not, the date is not the same. And what we have found that is definitely happening within our labor and delivery when we're discharging new moms. And that's because a physician may come and see their patient on Tuesday afternoon, knowing they're going to discharge on Wednesday morning. And so they're going to go ahead and provide all the scripts at that time on Tuesday. Again, I always use the analogy, if you can tell that story, then you're able to say, patient was seen on Tuesday at 3 p.m., discharged Wednesday at 10 a.m. So you can see that, yes, it was your patient, provider, all of that information. And then we also have some columns where we keep notes, any follow-up, if I need to reach out to, let's say, Walgreens specifically. And then I always keep that on one document. So I know anytime that I pull that up, what we're waiting on, when it was sent to them, or the request was sent to them. And then I also include the date closed and any notes based on what we either found internally or the correspondence back from Walgreens. And I like this, it takes a village. So 340B is not just 340B team's responsibility. As I've said, over and over, there's so many different aspects to 340B compliance, and it hits different departments. So remember, legal, revenue integrity, patient accounting, bring in your hospital compliance, ask them to sit on your 340B steering committee, ask your AO to sit on that meeting in that committee. And it's not that necessarily that they are able to attend every meeting, but it's bringing them in. So basically they know any changes because you're going to have minutes, you're going to provide that to the group. And so they know what's coming. I know, for example, again, recertification, I reached out to the AO, just want to let you know, they're also sent daily emails saying, you need to complete this, you need to complete this. And so open that line of communication. I just told my AO, as soon as I am finished completing all of the tasks, then I will let you know so you can go in to the system, log in and attest to the recertification. I also developed some yearly 340B education requirements and specific to roles within the CE. Your buyers are going to have a different education than possibly your actual pharmacy managers or your clinical specialists or different things like that. So make them specific to the roles within the organization. 340B education, in my opinion, should be part of the onboarding process. That new employee orientation checklist that we all have in pharmacy, it needs to be on there. And the way I always devised the 15-minute session was specific to their role. This is why we need to make sure that you document waste each and every time. This is why we need you to make sure that you're scanning when you're actually putting that compound together, so we know what drugs are being used, so we can tie everything appropriately within the accumulators. Very, very important. Again, Apexis has started putting out more and more webinars. definitely very, very informative. Look at those. You might also look at your 340B software. Do they have webinars? Are they having sessions to educate and have an open forum to where they have a guest speaker and their clients are able to ask questions? Review your retail purchasing activity. Everyone's a little different when it comes to the contract pharmacy piece. Are you allowing your retail pharmacies to push those orders, or is your 340B team pushing those orders? I have it worked both ways. And when the pharmacy is responsible for pushing orders, make sure you're looking at those accumulations, because it seems to never fail. A script will qualify on Monday. You may order, or they may process an order on Tuesday, but then the script is reversed on Friday. Well, who's non-compliant? The CE. Now we have purchased a 340B drug without a qualified script. So open those lines of communication. Do you want to hold 3 days before those scripts qualify within your software? Do you want to hold 5 days? What does that look like? Oops. And then again, develop an external plan, request an RFP, look at different audit companies, look at their experience. Do they have auditors that have been in what I call the nuts and bolts of pharmacy /340B? Or what is their education, their knowledge? Look at that. You definitely want someone that has been in what I call, again, the nuts and bolts, actually ran a program or been involved in compiling a compliance plan for 340B CE. So definitely look at those and request that, send out an RFP stating, here's what we're looking at. We're looking at a 3 or a 5 year plan. This is how many CEs we have. This is child sites, all of that information. And then I think we've all come to the realization that manufacturers are doing or have been doing a lot of different things over the course of about a year. We know about Novartis. HRSA came out with a letter, says, hey, you can't do this. We're going to actually impose penalties on you. Then lawsuits followed. And we all know how quickly lawsuits can get through the system. Just last week, Merck sent out letters that said, so Merck was one of those manufacturers that said, okay, covered entity, you can still have access to 340B pricing, but you have to register on 340B ESP. So all these CEs registered, some of them chose not to upload the information. It didn't say that they had to upload it. It just said you had to register. So there were CEs that registered. Well, now Merck has come out and said, okay, CEs, if you don't update or upload your script data, then we're going to withdraw 340B access to pricing. So that's kind of the latest and greatest. I'm sure there's probably going to be other manufacturers that follow. There's a lot of conversation back and forth in Washington, D.C. with, especially with COVID. We're in the midst of a pandemic still, and we have people that are actually putting bills on the floor that says, a 340B CE shouldn't lose eligibility because we are in the midst of a pandemic. So it's going to be interesting to see what comes out and what happens and when does it happen. It needs to happen before those CEs have to file their cost reports or have to terminate from the program. So we'll see how that all works out. And there's always something going on, not only from a manufacturer, but also from the Washington, D.C. aspect. Just into the defense of 340B, again, unfortunately, a lot of the documentation or regulatory guidelines can be interpreted multiple ways. And that's what's happening. Like I said, just like HRSA came out with a clarification last year about it doesn't have, your provider-based clinic or your offsite doesn't have to be on the cost report for you to actually immediately qualify that, as long as it's going to be on your next Medicare cost report. And so it's all interpretation. And I know when I started in 340B, it was almost a scary situation, so to speak, because you're being fed all of the stuff about how you have to be compliant, you have to be compliant, but then there's such little actual help, so to speak, or guidance or regulatory guidance on what that means. We know that HRSA is looking for duplicate discount and diversion. And so it's definitely interesting just over the course of the last few years how there have been additional resources to help a CE understand truly what's going on and how different parties are looking at it. So definitely keep your eye out for upcoming regulatory information and, of course, the lawsuits that have been filed. This is just a little bit of the DISH legislation, like I talked about. They're trying to protect hospitals from losing their covered entity status, especially during the pandemic. I can speak from experience in the sense of we're hoping that this passes for one of our CEs. They're registered as a DISH, which is that greater than 11.75. And we're hoping that this does get passed to where they don't lose eligibility. So that is the end of my presentation. Definitely open to any questions.